two pathways when PSA is elevated. Pathway 1, doctor recommends biopsy immediately. Pathway 2, MRI performed first. Biopsy only if MRI shows suspicious area. The difference? 50% fewer biopsies needed. Same cancer detection accuracy. Study published New England Journal of Medicine compared both approaches in men with elevated PSA. Standard pathway? All men received immediate biopsy. MRI-first pathway? MRI screened first. Biopsy only when MRI indicated necessity. Result: 44% reduction in biopsies performed. 94% of clinically significant cancers still detected. This isn't experimental. This is published, peer-reviewed research. American Urological Association now recommends MRI before first biopsy. Yet study shows only 28% of urologists routinely use this approach. 72% still recommend immediate biopsy without MRI screening. The hidden risk? Not the biopsy itself. The risk is having one when you don't need it. Today, why unnecessary biopsies happen, the information many doctors don't provide during appointments, and how to ensure you get the safest diagnostic pathway. If your doctor recommended biopsy without mentioning MRI first, this information could change your decision. Now, before we move on, a quick reminder. This video is for educational purposes only. It's not medical advice, and you should always discuss biopsy decisions with your doctor or urologist, especially considering your individual PSA level, family history, and health status. And if you'd like a free biopsy decision guide, just comment the word SHIELD below. You'll find the link waiting in the pinned comment. It's a simple, one-page chart to help you understand your options and ask the right questions before agreeing to any procedure. Now, let's get specific. Here are the 3 hidden risks that aren't about the biopsy itself, but about whether you need one at all. Hidden risk number 1, 70% of biopsies find no cancer. Study examining over 100,000 prostate biopsies found 70 to 73% came back negative. No cancer detected, meaning 7 out of 10 men undergo the procedure, experience recovery period, wait anxiously for results, only to learn their prostate is healthy. Why such high negative rate? Because PSA elevation doesn't always indicate cancer. Benign prostate enlargement causes elevated PSA. Inflammation causes elevated PSA. Even vigorous exercise or recent activity can temporarily elevate PSA. Traditional approach, PSA above 4.0, recommend biopsy. Result: many procedures performed when cancer isn't present. Here's the hidden part doctors often don't explain. You could know beforehand whether biopsy is likely necessary. Precision trial, New England Journal of Medicine. Among men who received MRI before biopsy decision, 61% had negative MRI showing no concerning areas. Those men avoided biopsy entirely. No procedure, no recovery, no waiting for negative result. The men with positive MRI findings who proceeded to targeted biopsy, detection rate of clinically significant cancer was 38%, much higher than standard approach of 26%. Study from Sweden examining 23,000 men. When MRI introduced before biopsy decisions, proportion of men undergoing biopsy decreased by 16%. But detection of aggressive Gleason 7 or higher cancers increased 24%. Translation: fewer procedures overall, better cancer detection when procedures performed. This information should be standard in every PSA conversation. But research shows it's not. Survey of urology practices. Only 30% of men with elevated PSA offered MRI-first pathway despite guideline recommendations. That's the hidden risk. Not knowing this option exists before agreeing to procedure that may be unnecessary. Hidden risk number 2, a 97% safer method exists, but most facilities don't mention it. 2 approaches for prostate biopsy. Approach 1, transrectal. 99% of U.S. procedures use this method. Access through rectal wall. Approach 2, transperineal. Access through skin between scrotum and anus. Avoids rectal pathway entirely. Why does pathway matter for safety? The rectal wall has natural bacterial environment. Even with preventive antibiotics, some procedures lead to complications requiring medical treatment. Transperineal approach uses different pathway, bypasses this concern completely. Research comparing both methods. Systematic review published 2025 analyzed 10 randomized controlled trials involving over 4,000 procedures. Finding transperineal approach reduced risk of requiring hospitalization for complications by 77% compared to transrectal. That's not 77% fewer total complications. That's 77% reduction in complications, serious enough to require hospital admission. Study from Fox Chase Cancer Center comparing both approaches. Complications requiring medical follow-up occurred in 1% of transperineal cases versus 14% of transrectal cases. Cancer detection accuracy. Multiple studies show equal or slightly better with transperineal, especially for anterior prostate region. European Urological Association reviewed all available evidence. Their conclusion: recommend transperineal as preferred method based on safety profile. So why isn't transperineal standard everywhere? Practical barriers, different equipment needed than most facilities currently have. Many urologists trained primarily on transrectal technique sometimes requires sedation rather than just local anesthesia. Changing established procedures requires institutional effort and investment. Result: despite being safer according to published research, transperineal remains uncommon in United States, but increasingly available at major medical centers. Memorial Sloan Kettering, Mayo Clinic, Fox Chase Cancer Center, many academic hospitals now offer it. The hidden risk: your facility might offer transperineal but doesn't mention it unless you specifically ask. Or your facility doesn't offer it but could refer you to one that does if you request it. Information you should receive during informed consent but often don't. Hidden risk number 3. What doctors tell you versus what research shows you should know. Study from Patient Education and Counseling Journal examined 200 actual doctor-patient conversations before prostate procedures. Researchers recorded consultations, then compared what was discussed against medical literature on outcomes, alternatives, and success rates. Findings: 81% of conversations included minimal or no discussion of MRI-first alternative, even when facility offered it. Only 37% mentioned the 70% negative biopsy rate. Fewer than 20% discussed transperineal option when available at that facility. Average time spent on informed consent: 11 minutes. Recommended time for complete informed consent on procedure with multiple alternatives: 25 to 30 minutes. Why does this gap exist? Time constraints. Appointments scheduled for 15 minutes total. Not enough time for thorough discussion. Institutional patterns. Facilities offer what's established. Discussing alternatives to standard pathway requires extra effort. Assumption of patient preference. Some physicians assume patients want simplest path forward, not detailed analysis of options. Knowledge gaps. Not every doctor stays current on latest research showing benefits of newer approaches. Result: patients making decisions based on incomplete information. But research from Annals of Internal Medicine demonstrates when patients receive thorough information before procedures, outcomes improve across the board. Better preparation, decisions aligned with personal values, less anxiety regardless of results, higher satisfaction with care. Incomplete information doesn't protect patients from worry. It prevents informed decision-making. The hidden risk: agreeing to procedure without realizing you had other options worth considering. So how do you ensure you're getting complete information and safest pathway? Question 1. Before scheduling biopsy, can we do multiparametric MRI to see if biopsy is even necessary? This follows American Urological Association guidelines recommending MRI before first biopsy. Most insurance covers prostate MRI for elevated PSA. Medicare covers it. If doctor says MRI unnecessary, respond, I understand that's your usual approach, but I'd like to follow the AUA guideline recommending MRI first. If MRI shows concerning areas, I'm willing to proceed with targeted biopsy. Question 2. What percentage of biopsies at your facility come back negative? This reveals whether facility tracks outcomes. Should be around 70% nationally. If significantly lower, facility may have better patient selection using MRI or biomarkers. If they don't know the number, that's information worth having about their quality monitoring. Question 3. Do you offer transperineal biopsy? I understand research shows better safety profile. If yes, what's your complication rate comparing transrectal versus transperineal? If no, can you provide referral to facility that offers transperineal approach? You're not being difficult. You're being informed about published research. Question 4. If biopsy detects low-grade Gleason 6 cancer, what monitoring options exist besides immediate treatment? This establishes you understand active surveillance as option for low-risk findings. 70% of men with Gleason 6 now choose monitoring over immediate treatment. Question 5. Are there biomarker tests like 4K score or prostate health index that could help assess my individual risk before deciding on biopsy? Shows you're aware of additional testing options that provide information beyond PSA alone. Not all insurance covers these, but worth discussing as tools for better risk assessment. Question 6. Can I have some time to research these options and schedule follow-up appointment to discuss decision? Medical decisions rarely need to be made same day unless emergency. Elevated PSA is not emergency. Taking a week or two to research, possibly get second opinion, is completely appropriate. Any doctor uncomfortable with patient taking time to make informed decision is providing information about their practice style. Let's bring everything together. The trap isn't that prostate biopsy is dangerous procedure performed by incompetent doctors. The trap is the information gap between what research shows are best practices and what patients are routinely told. Gap between guideline recommendations and actual clinical practice. Gap between available options and options presented during appointments. 3 specific gaps we covered. Gap 1, 70% of biopsies unnecessary. MRI-first approach could prevent half of them, but only 30% of patients offered this option. Gap 2. Transperineal method has 77% lower serious complication rate than standard transrectal, but rarely mentioned even when available. Gap 3. Informed consent conversations average 11 minutes when research says 25 to 30 minutes needed for complete information. These gaps exist for understandable reasons: time pressure, institutional inertia, training patterns, knowledge lag. But understandable doesn't mean acceptable when we're talking about your health decisions. You deserve complete information, not to challenge your doctor's expertise, to make decision that's right for your situation. Research clearly shows benefits of informed pathway. MRI first prevents 40 to 50% of unnecessary procedures while maintaining 94% detection of significant cancers. Transperineal approach reduces serious complications by 77% with equal cancer detection. Complete informed consent improves patient outcomes regardless of which pathway chosen. These aren't opinions. These are findings from New England Journal of Medicine, systematic reviews, guideline committees. The questions we covered aren't confrontational. They're informed. They demonstrate you've done research. You understand your options. You want to make best decision with complete information. Good doctors respect informed patients. Welcome these questions. Provide thorough answers. If you encounter resistance to basic questions about guidelines and alternatives, consider that information too. Remember, comment Shield for your free biopsy decision guide with all these questions formatted for your appointment. If this was helpful, tap like and share with any man navigating PSA or biopsy decisions. Subscribe, because next week we're covering active surveillance for low-grade prostate cancer and why most men with Gleason 6 findings now choose monitoring over immediate treatment. The hidden risks quietly ignored aren't medical secrets. They're information gaps in routine clinical conversations. Gaps you can close by asking the right questions. By requesting the options research shows are beneficial. By taking time to make informed decision rather than automatic agreement. Your prostate health is important. The decisions you make about testing and treatment matter. Make them with complete information, not the abbreviated version. Ask the questions, request the alternatives, take the time. Your informed decision.